Hello and welcome to Benefits Weekly. This week we've got an exciting topic. We're going to be talking about direct primary care. Everybody's talking about DPC, it's all the buzz. And so importantly, we thought we'd bring in a real expert, our first special guest here on Benefits Weekly, Dr. Eric Bricker. Woo! We're excited. If you work in employee benefits, you've probably bumped into his work. He's a renowned educator. He's an entrepreneur. He's a physician. He's truly a man of many talents. And there's no one I know more within our kind of circles that really evangelizes and also understands direct primary care the way that Dr. Bricker does. But Dr. Bricker, I'm going to go ahead and let you introduce yourself to our audience.
Yeah, thank you, Kyle and Eric, for having me on, and thank you to all the listeners. Yeah, so I am an internist. I went to medical school at the University of Illinois and then residency at Johns Hopkins in Baltimore. Actually, used to be a hospital revenue cycle consultant before going to medical school, and I actually started a healthcare navigation company with some business partners while I was in residency, and it was founded in Dallas, Texas. So after my residency, I moved down to Dallas, and it was called Compass Professional Health Services, and we grew it to about 2,000 employer clients, about 1.8 million people. And so for 11 years, we helped people navigate the US healthcare system, and we learned a ton. Sold the business in 2018 and then took a lot of that experience and like, hey, let me kind of educate the public about everything I learned. And so that's where these A Healthcare Z videos come from. And I put them on LinkedIn, and I've got a YouTube channel as well. And believe it or not, it's got like millions of views and over 100,000 people are subscribed to this thing. So it's kind of shocking that people want to learn about healthcare finance. Tends to be a rather dry topic. Um, and then a couple of years ago, I got involved with a direct primary care company called Frontier Direct Care, and I'm on their board of directors. And so I love talking about direct primary care, and I'm looking forward to the conversation.
Dr. Bricker, thank you very much for being here. On a personal note, I know that you and I have known each other for I think it's going on 2 decades now. I know Kyle
Yeah.
has known you for 6 or 7 years, so we're very excited to have you here as a guest. I guess the I know you in your videos kind of like to do the who, what, where, when, why, how, type approach to education. So I think maybe we can kind of follow that in this discussion.
Sure.
So I guess the first obvious question is, what is direct primary care? Because I think a lot of people out there, they've heard the term, but they're probably like me and they know just enough to be dangerous and probably could use a clearer understanding.
Yeah. No, that's a great place to start. And I'd say you're right. That a lot of people don't know what a direct primary care DPC is, and so it is access to a PCP via a subscription. So instead of paying for each office visit, what we call fee for service, you actually pay a monthly subscription for unlimited access to the physician and their staff. And so it involves the in-person visits, it involves the telemedicine as well. And it really started about 15, 20 years ago in places like Kansas and Washington State, were the really early ones. But believe it or not, there's like thousands of direct primary care practices across the country, and they tend to be primary care physicians, so internal medicine, family practice, pediatrics as well. And that subscription is either paid for by an individual, so as an individual you can sign up for it, or there's sort of this growing movement of employers paying for direct primary care on the part of their employees and their family members. And one of the big differences with DPC is that there's no bills. There's zero billing whatsoever. So you'll never get a bill to be like, oh, well, you owe $5 or $10 or $100. Like that will never happen because you pay your subscription, and there's no claims and there's no bills submitted to the insurance company. And so when the employer pays the monthly subscription, oftentimes, usually the patient has zero out of pocket costs. So it's a huge benefit in terms of not having sort of a financial barrier to go in and see the doctor or the nurse practitioner, the physician's assistant, what have you, because the a lot of people that use direct primary care, a lot of times they're of modest means, and so this way they're not like, "Well, I'll just ignore whatever sort of medical problem I'm having because I don't feel like paying to go to the doctor, because this way it's zero out of pocket."
So this sounds like a lot more of a concierge type service than what a typical doctor visit is. So I think that an obvious question that people are going to have is, we've also heard the term, concierge medicine or
Yeah.
concierge doctor. How is this different from that arrangement, or is it the
Yeah.
same thing?
So it's a great question because it is a nuanced but very important difference. So a concierge practice will charge a subscription, and that could be like a monthly or like a 1 year membership fee, but the concierge doctors will still bill your insurance. So if you've got Blue Cross, United, Cigna, Aetna, they're going to bill your insurance. So it's essentially like going to a regular office visit, except they provide like more hand holding and 24/7 access. You can call them anytime. And so they charge you that yearly or monthly subscription for that better access, but they're still going to bill your insurance. Whereas direct primary care does not bill your insurance at all. And that's important from an incentive standpoint because one of the keys to the effectiveness of direct primary care is you have longer patient visits. So, one of the reasons when you go typically see your doctor, the average patient visit is only 15 minutes, and only half of that is the time between the doc and the patient. So, about 7.5 minutes face to face between doctor and patient. The other 7.5 minutes is the doctor spent doing the documentation and all the paperwork, et cetera, et cetera. And so, as an internist, and I'm sure you could ask any primary care physician out there, it is impossible to perform appropriate primary care in 7.5 minutes. I mean, you just need more time. And so the reason those visits are so short is because they're getting paid per visit. And so oftentimes the primary care docs that work for large hospital systems, they even have quotas. They're like, look, you got to see 25, 30 patients a day because you're billing fee for service. You got to bill for 25 or 30 patients and you've got to generate that revenue. Whereas when you're charging a flat fee subscription, you're not rushed to. So you're instead of being 7 minutes face to face, they're 30 minutes, 45 minutes, hour-long visits. And one of the ways that the direct primary care physician is able to have those longer visits is their typical patient panel is about 800 patients total, whereas your typical community primary care doc, their typical patient panel is anywhere from 2,500 to 3,500
Oh,
patients.
wow.
And so the typical metric is that a DPC doctor typically sees about 1% of their patient population every day. So if they got a patient panel of 800, they see about 8 patients a day, which means that they've got about 8 hours to see those 8 patients. And what's great is that it also gives you the flexibility to have in-person visits, or you can have virtual visits, or of course, if you get lab work done, or if you get like imaging studies done, sometimes the doc's like, well, you have to come into the office to discuss your results. Well, sure, you don't need to do that. I mean, you can do that on the phone. A lot of the times the doc is having you come in for an in-person visit so they can bill for it. But in DPC, because they're not billing for it, you don't have to come in person and be like, okay, your sodium is this, your potassium is this, your kidney function is this, your blood level is that. And you don't need to come in to do that. So even if your direct primary care physician is like very close, they could be like 2 miles away. People are busy. Working moms, I mean, they're super busy, right? So this way you can still just have like a telemedicine or a virtual video visit as opposed to actually coming in. So it allows for tremendous flexibility, which really ends up being not only much more convenient for the patient, but it allows you to frankly provide much better care.
I think what's interesting about that is you get more time for the visits that actually need to be done in person, but then it's more efficient on the things that don't really need to be done in
Yep.
person. So you save time while getting more face-to-face time. Kyle, did you have any follow-up questions on the what is it question?
No, I think you hit an important distinction there between the concierge and the direct primary care because I feel like I've heard those terms used interchangeably. So I kind of like the distinction you provided. So thanks for doing that.
Definitely. Well, I think, obviously, you hear all this, it sounds great. I'm guessing though, there is, it's going to be a better fit for some people than others. So who would you say is a good candidate for direct primary care?
Yep. So as you can imagine, one of the keys, especially for the employers that are signing up, with a direct primary care group for their employees is that there is a certain degree of geographic concentration of the employees, and so it tends to be municipalities and school systems and universities, and then even like construction and manufacturing, because they still have that generally have the employees in somewhat of a similar area, and I mean, post COVID, even relatively small companies with like 50 employees sometimes they're spread out across like 3 or 4 states. And so there, if you got 5 employees in one state and 10 employees in another state, that generally is just too spread out for a direct primary care group. Okay, so geographic concentration is number one. Number two is it tends to be for blue collar and gray collar jobs because a lot of times people may not realize this. The vast majority of employees like do not have a primary care physician. Okay. And so oftentimes blue collar and gray collar employees, they're just going to urgent care in the ER as their like primary care doc. Like they don't have one. So when you give them access to a direct primary care physician at zero out of pocket cost, you're not like pulling them away from an existing relationship with an existing primary care doc. Everybody's like, well, what if they already have a doc and they really like them? Like, that's great. But I'll tell you what, if you survey your employees, the vast majority of your employees do not have a tight relationship with their primary care doc. And even if they do, again, after COVID, it's so hard to get an appointment. So even if you have an established relationship with a primary care doc, they'd be like, oh yeah, our next available appointment's in 4 months. And it's like, whoa, I gotta wait 4 months. It's like, I like you, but I don't want to wait 120 days to see you. And because those direct primary care docs have smaller patient panels, like it's usually same day, next day appointments. Like it's very easy to get in because they have so many more open slots than your typical community physician were. So, tends to be geographically concentrated employers, tends to be blue collar and gray collar workers that don't already have an existing relationship. And then the types of companies that tend to want to do this too, really the whole reason why an employer would want to do direct primary care is because, this is getting a little health insurance like wonkiness, is that like the healthcare costs are all about what's referred to as the Pareto principle, where 80% of an employer's healthcare spend really comes from 20% of the plan members. And those plan members are the high cost claimants. Those are people with $50,000, $100,000 worth of claims. And the challenge is that a lot of times those high cost claimants, they kind of come out of nowhere, right? It's like, okay, it's not like they had high cost claims the previous year. It's like all of a sudden they just kind of explode with some sort of, they might have had a heart attack, or they might have had acute renal failure, or a real bad case of pneumonia that puts them in the hospital. And so, really, direct primary care is an employer's high cost claimant strategy, right? So, in order for an employer to move the needle at all on their healthcare costs, they got to do something about their high cost claimants. And historically, the way they've tried to do that is tried to be reactive. But once they already become a high cost claimant, then we'll try to get involved with them and help them. Guess what? The train's left the station. It's too late. And so, what you're doing is you're engaging with your health plan population around making them healthier, identifying chronic disease, treating chronic disease, keeping them out of the ER, because it's like an ounce of prevention is worth a pound of cure. If you try to reactively address your high cost claimants, like that does not work. Employers have been trying that for decades and it doesn't work. And so employers that have put in place a zero out of pocket primary care for their employees, it really gets out ahead of their high cost claimants, and you really see it lower the overall cost. I mean, it's crazy expensive, right? Healthcare costs for a family of four is like 32 grand a year now. It's like crazy expensive. And so the employer is trying to run a business. And so this way you can actually proactively keep the employees healthier and dramatically drive down your claims cost.
It's interesting. I think the most surprising thing, Kyle, I don't know if you agree, but to me, the most surprising thing that Dr. Bricker has said at this point is I think of, again, a lot of people use concierge medicine and direct primary care interchangeably. And I think a lot of people think that is a solution for the wealthy, where Dr. Bricker said this is primarily a good solution for blue collar workers for all the reasons you just said. And so I find that interesting. And you kind of answered what my next question was going to be, which is, why does this work? And I guess to paraphrase, it's because a lot of people don't have a doctor, can't afford to see the doctor, or can't get in to see the doctor because of the wait time. And so they delay care. And so minor things become major things. And suddenly they turn into a high cost claimant. So this is a much more proactive approach for employers. I know that's some of your points. Would you add anything on the why does this work question?
Yeah, I would say that the the overall relationship that that employees, or patients in general have with their healthcare provider um is really lack of a relationship. I mean, it's really like gone. primary care has basically been decimated in America. And so much around keeping people healthy and driving them towards behavior change for healthier behaviors. I mean, believe it or not, 17% of the US population still smokes cigarettes, right? And so like the 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 physician has a tremendous position of authority. And the only way, just because people, and I will say that really that's because of pediatricians. Okay, pediatricians are wonderful people. And so when you're a kid and you go to the doctor as a pediatrician, you're like, oh, these doctors are wonderful because you kind of form your opinion of doctors as a child. And like 99.9% of pediatricians are like wonderful, right? And so you have this great um, um, ethos, or you have this great credibility with the patients. But if you don't establish a relationship with them and learn about them as a person and understand their household and their family and their job and their community, if you don't have a relationship with them, then you're going to have a really hard time impacting their health. And so, really, with people, fast is slow and slow is fast. And so, you really have to slow down to build the relationship with the patient. And guess what? That relationship is not some like soft, touchy feely, esoteric thing. I mean, it literally keeps them healthy and it keeps them out of the ER and it keeps them out of the hospital because nothing effectively happens unless there's trust. And trust doesn't happen unless there is a relationship, right? There's somebody who said, there's nothing faster than the speed of trust. And so
Yeah.
you've got to establish that relationship and that trust. So to really explain why it works, it's because you have time and you have continuity because people don't have a relationship with like Frontier Direct Care as a direct primary care practice. They have a relationship with their individual provider. They have with the nurse practitioner, what have you. That's really where the magic happens, is individually between the provider and the patient. And so, you know, I'm kind of telling you the secret, right? Like that's really why it works. It's highly relationship driven. So if you have any, some people are like, well, we have an on-site clinic and a near-site clinic, and it doesn't work. Our claims keep going up. And interestingly, their number one complaint is, well, the clinic has high turnover. There's a lot of different docs coming in through the clinic. Well, of course, your clinic's not going to work if every time your employees go in to see the doc and it's a different doc. Then they don't have a relationship with them and they don't have trust, and therefore it doesn't work. So anyway, I let the secret out of the bag. It's highly relationship.
It's funny. Kyle and I work in the employee benefits industry, and we like to say, and I think it is true, that relationship, it's very personal relationship. It is about trust. That's important. So I think a lot of the advisors out there that are watching, just because of the way we do business, we can kind of relate, same thing, advisor, employer, doctor, patient, there does have to be a relationship there. It can't be transactional. So totally makes sense. Kyle, do you have any follow-ups?
Yeah, just one. I mean, I guess from the patient experience, Dr. Bricker, do you know if, I'm thinking about that trust factor you just brought up. Does the lack of kind of the billing probably contribute to that trust? I.e., like I'm not sitting there in the exam room wondering what this shot or test is going to cost me. I mean, what's that patient kind of journey and consumer experience look like?
Yeah, it's a big part of it because a lot of people like their doctor. Okay, so like the vast majority of physicians have good bedside manner and good rapport with their patients, but it's a total trust killer where then your experience with the billing and the office is a nightmare. And so it is to make things as simple as possible by just removing the billing dynamic completely. Does really foster a much better relationship with patients.
Mm. Yeah, I could see how that would be something that just contributes to accelerating the building of trust. And you already addressed my other question I had in my mind, which was, okay, you talked about employers with concentration. The other thing we've been telling employers with high concentration is invest in an on-site or near-site clinic. But to your point, it sounds like a lot of people treat those maybe more as transactional, urgent care experiences versus longitudinal relationships. And so that's a really important distinction. I appreciate you drawing that out.
Definitely. So we've kind of talked about the what, the who, and the why. I think you've touched on where you said that this works best for groups that are kind of geographically concentrated. Um, could you expand on that just a little bit? I'm guessing it's because
Yep.
the DPC, it's not like a national network of DPC doctors in most
Yeah,
cases.
so it is. There's another distinction around the geographic concentration that's important too. Is that at the end of the day, it really makes the most sense for either level funded or self funded groups. And really, the good thing is that over the past, because being fully insured has just become exorbitantly expensive. That more and more groups are going level funded and self funded at smaller groups, right? So it's actually fairly common now for a group of 75, 100, 150 to be like self funded, and they'll go out and they'll be part of like an insurance captive for their stop loss. So it's like totally doable because there, when the employees are incurring fewer claims, you as an employer, you want to recoup that savings. And if you're fully insured, it's really just the insurance company that's recouping the savings because you're paying a fixed premium out to them. And so being self-funded is super important. And Eric, to your point, there actually are some geographic distinctions around self-funding in America. So self-funding in America is more common in the Midwest and the South. And for sort of historic reasons and sometimes for state regulatory reasons, the Northeast and the West Coast tend to have fewer self-funded groups. So they'll have like self-funded groups of like 1,000 or 5,000 or 10,000, but all that middle market, like, like 100 to 1,000 employees being self-funded, that's much more common in the Midwest and the South. And oh, by the way, what do you also have more of in the Midwest and the South? You got a lot more manufacturing in the Midwest and the South. And you have a lot more construction in the South because of the sort of the whole Sun Belt movement, right? It's like there's a joke about road construction in Texas. Every road in Texas is under construction currently, right? And all it always so there's gobs of construction work in the South, whether it's on housing or other types of construction. So those types of jobs and that type of self-funding does tend to occur in those places. Now, to your point, there's some employers where it's like, okay, well, they're geographically concentrated, but they might have like a factory in like 2 or 3 states. So they're concentrated, but they're not just concentrated in one state. And so there actually are newer sort of consortiums or like confederacies of direct primary care clinics that are trying to band together because typically a direct primary care clinic is also kind of geographically concentrated, right? So there's a group of direct primary care clinics in like the Detroit area that's under one particular doctor, and then there's another group of direct primary care clinics that might be in like Denver under another doctor. And so that employer might be like, okay, well, I got people in Detroit and Denver, but there you have to have sort of a consortium or between those two direct primary care practices. And believe it or not, there's actually more of a movement to that. So it's a little loose, and it can be a little inconsistent because not all direct primary care practices are created equal, right? Because I said it's very individual personality of the provider driven. And so there certainly are. I mean, you got to be careful. I think it's very important for any employer that's considering direct primary care physician to actually like get to know, the providers that are actually seeing the patients themselves, because that's really who's fostering the relationship. So you would want to know who these people are, whether it's, seeing them in person or having video calls with them or just seeing, videos of these folks. So you're essentially hiring these people as like a subcontractor or a vendor, if you will. So it's important to keep an eye on consistency if you're engaging with a consortium of direct primary care groups.
I'm going to jump in with a quick question on that because I'm just thinking about your point around there are certain, there's a group in Detroit. I know you're here in Texas. Question, are we at a point yet with this market where there's local competition between different DPC providers? So for example, if I had a 250 person construction firm here in Dallas, are there, a half dozen DPC firms I might want to look at and evaluate, or is it still pretty nascent? Like I've got one option, just wondering what that market looks like.
Yeah, so it's a great question, and it's very spotty. So in some places there is competition, and listen, believe me, I think competition is great because it causes everyone to have to raise their game. Right. So like the last thing you want is lack of competition because that just causes complacency. Right. So like, and believe it or not, one of the places where DPC really got an early start was in Wichita, Kansas, kind of a medium-sized town. Okay, it's not a huge metropolis, but it's still it's a big place, right? There's a whole bunch of different DPC practices in Wichita, Kansas, and they compete with each other. And they're like friendly competitors, but the point is you have a choice. If you're an individual or if you're an employer and you're in Wichita, Kansas, believe it or not, you actually have a choice of what DPCs you can go to, which is great, right? Everybody loves choice.
Awesome.
That's interesting. I think everything you said, I mean, I could see an employer quickly being sold on the idea. Um, the idea kind of still seems theoretical, though, I think, unless you kind of know how to do it. So two important how questions. One is how, if an employer does want to explore this, how do they actually go about finding a direct primary care practice, getting this implemented, and then probably just as important, how much is this going to cost? And I know the answer is going to vary, but if you can kind of give an idea of that.
Yeah, no, that's great. Typically, employers engage with a direct primary care practice. Typically, it's through their broker consultant, right? Because for a lot of these, we're talking a lot of mid-market employers between like 100 and 1,000 employees. They got very, thin, HR staffs. Maybe they got an HR, a benefits manager. Maybe they got a VP of total rewards, et cetera, but they're super stretched thin. And so they're really leaning on their broker consultant to help them in terms of identifying these vendors and vetting them, et cetera, et cetera. So I'd say the first place you would go is you'd go to your existing broker benefit consultant, and they should be able to help you. DPC is not some sort of like brand spanking new concept where the vast majority of brokers and consultants like don't know about it or are not familiar with it like they should be. And if you go to your broker consultant and they're like not familiar with it, then arguably you should go out and look for other broker benefit consultants. I mean, I think that's one of the great things, frankly, about the benefit consulting space is there's a lot of competition there. You actually have a lot of choice, right? So you don't have a ton of choice in terms of carriers, right? But you do have a lot of choices when it comes to your broker benefit consultant, which is great, which again, it causes everybody to kind of have to elevate their game to best serve their customer, the employer and the employee. So really, finding a broker consultant that you can, that has the sort of the bandwidth and the skill and the acumen to be able to engage with one of these direct primary care groups. And then what you as an employer, the big key there in terms of the success of the program is communicating it out to the employees. And so this is where really the best practice, because HR knows that sometimes not all the employees always listen to HR. Okay. So I think HR people would
Really?
admit that they don't always listen to us. Okay. And so to actually be, to have like executive leadership, like from the CEO and the COO and the management, and actually be able to communicate this out to the employees, not just through HR, but really have the CEO and the executive team champion this, and really to have communications around the direct primary care go through the management teams, right? So for some of these manufacturing clients, it's like the line manager literally is part of the communication mechanism out to the employees. Because when you're an employee, you don't really think about the CEO. You kind of think about your immediate boss, right? And so a lot of direct primary care groups, Frontier included, we actually have our clinicians reach out directly to the patients to be like, hey, I'm your doc. You can call or text me whenever you want, et cetera, et cetera. But as you can imagine, unless the employer talks to the employee first, what's the employee going to do? They're going to think it's a scam, right? Yeah, right. This is a free doctor. Click, right? And so they've got to get, sort of, okay, so listen, and the employer's like, your clinician is going to contact you. Like they're going to call and text you. So when that happens, like it's for real. We as the employer have paid for this for you. And that's worked out great, right? Because the employer has limited bandwidth in terms of like repeated communication, et cetera, et cetera. But at least to be able to give them the initial heads up so that when the direct primary care clinicians do the reach out, the people are like, okay, I understand. And that's super important also for spousal engagement, because for a lot of employers, it's not the employees that are driving their claims, it's the spouses. So that way, and postcards and giving stuff to the employees to take home to their spouses. I mean, there's a gazillion ways to do it, but that's the kind of partnership with the employer that makes it successful. Oh, and then cost, right? It's anywhere from $50 to $100 per member per month. And you're like, whoa, that sounds kind of expensive. And so that's where the key is that a lot of direct primary care groups are really, putting their fees at risk. I mean, the whole point of the program, it needs to financially justify itself, right? This is, we are in a time where because of inflation, everything has become so expensive from a business standpoint, right? The business has labor inflation that they have to pay for. They've got material and product inflation that they have to deal with. And so like we're not obviously, money doesn't grow on trees. And so the DPC program actually has to financially pay for itself in order for the employer to justify the expense. And so really being able to have, some or all of the fees be contingent on savings is super important to really align the incentives, because other times too, I've heard of other clinics where it's like, well, if it's 4 p.m. on a Friday, the doc's going to be like, well, just go to the ER, right? Well, you know what you do? You do not want the doctor doing that at 4 p.m. on a Friday. I mean, that could be an $8,000 ER visit that didn't need to
Yeah.
happen just because it was Friday at 4. It's like, no, you need to have the clinicians hustle so that if it's a Friday night or a Saturday morning or whatever, they're going to hustle with the employees to get them as care. And obviously, look, if they're having crushing chest pain or they're actively bleeding or whatever, like, of course they're going to tell them to go ER. But for all those other situations, for the vast majority of ER visits that are not actual emergencies, like, you want to make sure that the clinicians are making themselves available.
One follow-up question there. So if I am an employer and I'm self-funded, or I'm working with my benefits consultant, in order to kind of evaluate the ROI on this, maybe am I going to look at prior year claims? How much did we spend in total on kind of primary care related services, and then come up with kind of a number, and then maybe that number I compare to what would a DPC at 50, 100 PMPM cost? Am I kind of thinking about replacing my prior primary care costs with the
That is
subscription?
a fantastic question, because the short answer to that is no. There's a
Oh, okay.
terrible way to think. And by the way, this was not scripted. I did not know Kyle was going to ask me that in advance. Okay, like that, I've seen other brokers do that. Like that. No, that is not where the money is coming from. The money is coming from your high cost claimants. All right. So what you want to do, if you're like, okay, well, what kind of opportunity do I as an employer have? Is you just look, to the extent that you get any claims detail, right? And it's all over the map. Some carriers give a lot of claims detail, other carriers don't give a lot of claims detail. You would want to specifically look at your hospital and your ER visit and your specialist spend. Okay. So literally, we see anywhere from 50 to 75% decreases in ER utilization as a result of direct primary care. We see 20 to 40% decreases in hospitalization as a result of direct primary care. And we see anywhere from like 20 to 30% decrease in specialist services because of direct primary care. Because a lot of people are just self-referring into a specialist because they can't even get into the direct primary care doctors, or they can't get into their primary care doc's office. So like, well, I'm just going to go see an orthopedist for my arthritis because he can see me next week, and my PCP can't see me for 3 months. It's like, well, listen, the vast majority of the time, you do not need to see an orthopedist for your arthritis. So it decreases your specialist visits as well. So anyway, long-winded answer to your question is, you look at your ER spend, you look at your hospitalization spend, and you look at your specialist spend, and that's where the savings opportunity from DPC comes from.
Wow. So I feel like we could talk all day, because it's an interesting topic, and I know there's a lot more to it. I have one final question, and it's mainly because I know that as insurance advisors, whenever we're recommending that clients make a change, whether it's from PPO to HMO or one carrier to another, one of the things that always comes up is the network question. And that's because people are attached to their current providers, or at least there's a perception that they're attached to their current providers, and employers are kind of scared to make a change. So when we're talking about employers making this decision and communicating to employees, do they get a lot of pushback from employees because they're going to be changing doctors? Or is it, like you said, a lot of people don't have doctors, so the pushback isn't quite as great as maybe the employers anticipate?
Yeah, so it's a great question, and I would say that the best way for an employer to figure that out is to survey their employees. So we've had customers at Frontier who actually, like, you can use Survey Monkey or whatever, survey, and you can make it anonymous or whatever, and you just ask them, like, look, do you have a primary care physician? When was the last time you saw him? Would you be interested in would you be interested in switching to a different primary care physician if you were able to see them same day, next day, and at zero out-of-pocket cost? And just see what they say. And in general, like I said, even at white collar employers, typically only about a half to a third of the employees have actually seen a primary care physician in the prior 2 years. Okay. So, like, primary care in America is dead. Okay. It is largely dead. So this whole idea that you're going to be ripping people away from their existing primary care doc, I mean, listen, whatever employer is like that, like, congratulations. You actually have your employees engaging in primary care. What? Like, great work. Tell me who you are. Okay. Because believe me, many employers in America, like, have tried to do that, and like, it hasn't worked. Okay. So like it really is not an issue.
Wow.
And then just one clarification on that. So let's say, though, it is a situation where I do need to go see a specialist after determination from my DPC visit, or I need to schedule a hospital procedure, or I've got a cancer diagnosis or something. Is the employer then typically pairing the DPC offering with a more traditional provider network in terms of the health plan itself?
Oh yeah, totally. You don't
Okay.
you don't get rid of your network. You don't get if you're self-funded, you're not getting rid of your ASO or your TPA. Like you keep all that, right? I mean, at the end of the day, like direct primary care cannot provide all medical services. Okay, direct primary care does not deliver babies. Okay, right? It's like, the most common reason for hospitalization in America is labor and delivery. And so women are gonna like want to go see their in-network OBGYN and deliver a baby at an in-network hospital. Like that's great. And to your point, like we refer to cardiologists and orthopedic surgeons and dermatologists and gastroenterologists like all the time. Like you got to go in for your screening colonoscopy if you're 50. Like your direct primary care doc is not going to do your screening colonoscopy. And so what's great is, and this is what we try to do at Compass, but at the end of the day, your navigation should actually be done by your primary care doc. Like that's their job, right? And most primary care docs don't do it because they don't get paid for it, right? In fee for service, they don't get paid for it. And so that is part of the overall service of direct primary care, is actually finding the specialists that, meet your need in terms of location and appointment availability and high quality, et cetera, et cetera. So you actually have the best of both worlds, where you like going to see the specialist. A lot sometimes, in fee for service, they're like, okay, we'll just go to this doctor because they're in the same hospital network that hospital group that I'm in. Well, shoot, well, maybe being in the same hospital group's not the right dermatologist for you or the right cardiologist for you. Maybe going to see somebody else would make more sense because of where you live or appointment availability. So yes, it's a great. You can almost think of it as like two parallel streams. You have your care without claims through direct primary care, and then you have your care with claims through your existing carrier. And what's happening is that you're getting a lot more care with claims you're getting a lot more care without claims through DPC, while you're getting a lot less care with claims through your existing network. It never goes away completely, but you're kind of doing this. And what that does is it dramatically improves the health of your employees, it improves the quality of their care, and it decreases the cost. So, and listen, it's growing like a weed. Okay, I mean, especially within the past like 5 years, DPC's growing like a weed because employers have woken up to the fact that this is so much a better way. So, I mean, the wave is already here. The question is, do you just want to ride it or not?
Well, that's amazing.
Well, Dr. Breaker, thank you so much. Really, really appreciate your time. I know this was very educational for me. I'm sure for our listeners as well. Is there anything we didn't ask that probably needs to be said before we wrap up?
No, listen, thank you so much for having me on. And I would say that if you're a broker consultant, I mean, part of your responsibility is to educate yourself about solutions. So, do some self-education around direct primary care. And if you're an employer, ask your broker consultant about it. Like you shouldn't have to reinvent the wheel. Go ask that advisor. That's why they're advising you.
Makes
Awesome.
sense.
Well, I think we'll leave it there. I'll go ahead and do our outro. First of all, I want to do a huge thank you. Thank you, Dr. Eric Bricker. Thank you, my co-host, Eric Johnson. This is an engaging conversation. I enjoyed just being kind of a fly on the wall for the majority of it. And to our audience, thanks again for tuning in. If you liked what you found here, the best thing you can do is share it with a friend. And thanks for joining us.
Thanks, everyone.